Bismillahirrahmanirrahim. Let's start. So we were discussing the antipsychotic treatments last time, and let's continue with it. Today's session will be a little bit short than before. So when the first episode psychosis happens, the the first thing is the diagnosis. Previously, it was like you know there was no fixed definition. So it used to be called first episode psychosis or FEP, and and before that there was no definition at all of the first episode psychosis. So it was just psychosis or otherwise acute and transient psychotic disorder, but there was no distinction between first episode and multi-episodic schizophrenia. Now there is a distinction. So there is a term of first episode psychosis and then first episode schizophrenia as well. So let's go on to the ICD-11 and see what are the definitions of first episode psychosis and first episode schizophrenia. So first episode uh, here it is called first of all there is a first episode acute and transient psychotic disorder. So we need to see what is that and what is the diagnostic guidelines. There are no diagnostic criteria in ICD-10 up till now until the criteria version comes, but there are diagnostic kind of rough guidelines. So we need to go with that. So acute and transient psychotic disorder, they say, is first episode should be to identify individuals experiencing symptoms that meet the diagnostic uh, requirements for acute and transient psychotic disorder, but who have never before experienced such similar episodes. So, and let's see what is the definition of acute and transient psychotic disorder. So what they say is acute and transient psychotic disorder is characterized by acute onset of psychotic symptoms that emerge without a prodrome. So there are no prodromal symptoms in uh, in the first episode psychotic disorder, like in the acute and transient psychotic disorder, and reach their maximum severity within 2 weeks. So the maximum severity is reached in 2 weeks. Symptoms may include delusions, hallucinations, disorganized thoughts, perplexity of confusion, disturbance of affect, catatonia like disturbance, and symptoms typically change rapidly. So they can be polymorphic, like sometimes they can be hallucinatory, sometimes they can be delusional, sometimes you can see manic picture, sometimes you can see depression, so, and even within a single day, and that's what it is called polymorphic in ICD-10. So both in nature and intensity, the duration of episodes should not exceed 3 months. That is the difference between the ICD-10 and ICD-11. ICD-11 said that it should be like it should resolve within a month. It is usually a 2 week episode and should resolve within a month. But here it is, they have extended the duration of acute psychotic disorder. So does not exceed 3 months and most commonly lasts from a few days to 1 month. So most commonly it is a few days to 1 month, and then it can be up to 3 months. Symptoms are not a manifestation of another medical condition or a brain tumor, and are not due to the effect of a substance or medication on the central nervous system, alcohol withdrawal, etc. So this is what it is, the acute and transient psychotic disorder. So previously it used to be anything more than 1 month was schizophrenia, and now anything more than 6 months will be, I think, schizophrenia. So let's go to the first episode, schizophrenia, and then there will be schizoaffective episodes as well in the same manner. So first episode, schizophrenia, it's just they say that they have all definitions, requirements of schizophrenia are covered, and are met, and the first episode in terms of symptoms and duration are currently met or have been met within the past 1 month. So, and this is the first episode. So the first episode should be identified to used to identify individual experiences, symptoms that meet the diagnostic requirement for schizophrenia, but who have never before experienced an episode during which diagnostic requirements were met. And then if it is currently symptomatic, that means that the symptoms have been present within the last 1 month. So now we see that schizophrenia definition, how it is changed in ICD-11. Because in ICD-10, we needed only 1 month to diagnose schizophrenia, and now it may be different. So let's see. Schizophrenia is characterized by this, this, and this. So the definitions are like the symptoms are the same. So there is no difference of symptoms in the ICD-11, and what will only the duration will be changed. So schizophrenia is characterized by disturbances in delusional thinking, hallucinations, cognition, affect, behavior, unpredictable emotional responses, psychomotor disturbances, persistent delusions, and experiences passivity. Symptoms must have persisted at least 1 month in order for a diagnosis to be assigned. So here it is still 1 month, and then there is a gray area of up to 3 months. You can still diagnose acute and transient psychotic disorder if you are sure that it is resolving, and then you can still say it is an acute and transient psychotic disorder. So up to 1 month, it is an acute and transient psychotic disorder. But then up to 3 months, you may say, oh, you don't want to diagnose someone with schizophrenia. So you can say it is a resolving acute and transient psychotic disorder up to 3 months. But if the symptoms are very clear cut, 1 month has passed, you can still call it schizophrenia. But I would personally wait for 3 months before giving a diagnosis of schizophrenia, because of the gray area between the first episode psychosis and first episode and this schizophrenia. And we should not, so there are two things in schizophrenia: we should not hurry too much in diagnosing, and we should not be too late either. So once 3 months have passed and you are seeing the patient, uh, instead of calling it first episode psychosis, start calling it as first episode schizophrenia, so that you are like you're doing all the possible the all the possible you're giving all possible treatments to the patient which should have been given to a patient with schizophrenia. So it still says 1 month, but because of the gray area between first episode and psychosis and schizophrenia, we'll give it a bit of 3 months. Before that, we will call it as first episode psychosis, and maybe up to 3 to 6 months we can call it as a first episode psychosis. And after, if you really want to be very kind of precise and very careful, maybe wait up to 6 months, call it first episode psychosis up to 6 months, and then after 6 months you can easily say, if the symptoms are there, that it's a first episode schizophrenia. So that's the difference between the first episode acute and transient psychosis and difference between first episode schizophrenia. Now the other thing is first episode of schizoaffective disorder. Uh, so first episode of schizoaffective disorder, and let's see. So schizoaffective disorder, uh, first episode should be identified to individually experiencing symptoms that meet the diagnostic requirements of schizoaffective disorder, including duration, but who have never experienced an episode before. So ICD-11, uh, it differentiates between the first episode and multi-episodic. And let's see the schizoaffective disorder. The guidelines are the same, that both the diagnostic requirements of schizophrenia are met, and a manic or mixed or moderate to severe depressive episodes criteria is met in the same episode of illness, either simultaneously, either the symptoms are there simultaneously or within a few days of each other. So let's go to the treatment bit now, that how to provide treatment and what are the treatment guidelines, and especially we are taking the guidance from the Maudsley Prescribing Guidelines. First of all, like Maudsley Prescribing Guidelines, the authors say that antipsychotics are not only for control, they are for prophylaxis as well. So it's not only that you need to control the symptoms and that's it. And we all know as psychiatrists, all the medications are meant for mainly for prophylaxis after the treatment is finished. Otherwise, the patient will relapse. Now, how long to continue? Uh, how long to continue for after a first episode psychosis or first episode schizophrenia? So the authors and the literature differs in that, but there is a consensus of 1 to 2 years. So the consensus is that give antipsychotic for at least 1 to 2 years based on different studies. And I did I wrote a literature review, and then we started a project in East London, and then I left that part of London, and I don't know what's happening to that project. But that was a kind of retrospective cohort study, that what we were doing, that we were seeing that how many people who were started on antipsychotics continued on antipsychotics after 2, 3, 4, or 5 years, and how many of them who stopped medication they relapsed, and how many people who did not stop medication they relapsed. So uh, 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 that was the study, and when I was there, my findings were that people, whenever they were stopping, whether it was 1 to 2 years or 3 to 4 years, 5 years, we are seeing a very high relapse rate in people. So the consensus is still that give antipsychotics for 1 to 2 years, but Maudsley Prescribing Guidelines, they tend to differ a little bit politically with the consensus. They say that they are more inclined towards giving for 5 years after the first episode schizophrenia, a minimum of 5 years, but they can't say that clearly because there's no consensus up till now. But there are studies, there are small studies, the studies are not very big, which favor giving antipsychotics for up to 5 years. And they say that the patient may relapse if you stop the antipsychotic.
But where's the charger?
So now, discontinuation versus maintenance, we have seen that how long to continue and duration of maintenance treatment. Now, the relapse rate versus maintenance treatment was 26%. According to one study, the relapse rate was 26% with medication, and 61% people relapsed who were taking only placebo in 6 to 12 months. And many other studies are there with the similar outcomes. One study showed that the relapse rate and hospitalization or hospitalization is halved if antipsychotics are continued for 5 years, even with the first episode psychosis. But the consensus is still that we give it for 1 to 2 years. Relapse may happen anytime within 2 years of stopping treatment. And now things are now moving towards 5 year maintenance treatment. Now, what they say is that it's not only what should be the treatment. So there is no kind of fixed pattern that what antipsychotic should be uh, prescribed in the first episode. It varies from center to center. Previously used to be olanzapine, but now if the patient comes as an inpatient and are very disturbed and having schizoaffective symptoms with mania, then of course the inpatient consultants, inpatient clinicians will start them on olanzapine, while in the outpatients the treatment way maybe the outpatients, the first episode psychosis team, they are more inclined to give not olanzapine, but like they are more inclined to give something like aripiprazole. That is the most favorite drug at the minute. Aripiprazole is being mostly used in first episode psychosis in some centers, especially in the center in London where I worked. Like aripiprazole was the drug of choice. And if somebody doesn't respond to aripiprazole, then they go to others. And they should, in the first episode, they should respond to aripiprazole. In the multi-episodic schizophrenia, they become aripiprazole resistant sometimes. So that's the choice of the treatment, but of course you have to see, and you can use any antipsychotic depending on the patient's tolerance, whether they are tolerating or not, and 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 how much antipsychotic and how strong antipsychotic is needed. Then the other thing the Maudsley Prescribing Guidelines say is the uh, that the medication is not the only thing in first episode schizophrenia. There are other treatments as well. So, and one thing they might not have mentioned here, in practice, when I was working in London in the first episode service, we what we saw was drug and alcohol problems were so common. So getting them linked with the drug and alcohol rehabilitation services and counseling services so that they can put a stop on their cannabis, and especially and then the synthetic cannabinoids if they are using. So that is very important in some cases who start like with their psychosis as a drug induced psychosis, or they start using drugs after getting psychosis in both cases. Other thing is family therapy, which is very important, and it is being widely done uh, in the first episode psychosis service, because when a person with the comes with the first episode psychosis, their family members are also in denial for a long time that their relative with schizophrenia has a problem. They will also think that he's just malingering, he's making things up, he's just behaving, it's their behavioral thing. And especially when they are using drugs, then the relatives are right, because using drugs is something optional and they are using with their free will. So but if they are not, what if they are not using any drugs for their symptoms? The symptoms are very genuine and they are genuinely distressed. So some of the family members are very understanding, some have difficulty in understanding, and some are over caring, some are neglecting, some are under caring, some are not understanding at all. So that's why family education programs, family therapy, very important in this. And after the family therapy, then CBT for psychosis, cognitive behavioral therapy for psychosis, uh, and hearing voices group therapy, or otherwise individual CBT for psychosis. Both are very important. How to deal with the hallucinations, and so in a manner that the hallucinations are not disturbing anymore. They will be still there, they will only be controlled by the medication. But with the therapy, the response of the patient may change, because most commonly patients start arguing with the voices, they start conversing with the voices, start two-way conversation. So that should not happen. And if that's happening, some patients get more distressed with the conversation. Some patients get relieved. If they are getting relieved with the conversation, then maybe let them do that. But most of the cases they are not relieved. In most of the cases they are distressed. So commonly by default we say to the patients that not to argue with the voices and ignore the voices. That's the most common. So in CBT for psychosis, these principles are taught. Then the other thing is occupational therapy, keeping them having a structured routine, and uh, uh, attending some activities created or arranged by the National Health Services. And then the other thing is employment support program. So if they are like in their 20s or 30s and they get stuck with schizophrenia, they are unemployed, the employment support worker will try to find some suitable employment for them, so that they can get re-employed. Maybe it may be of a less caliber, or like a less difficulty of the employment which they were doing already, but there may be some. So most of the cases are not able to get re-employed, but some patients do get re-employed, and some patients, they go back on the same employment. So employment support is another thing, and then the key worker is another thing. Uh, Key worker, or nowadays it is called care coordinator in the UK. So key worker is the person who, or the care coordinator, who coordinates all the care between psychiatrist, psychologist, occupational therapist, family therapist, and the employment support worker and addiction counselor. Now, what is the difference between uh, the first episode psychosis service and the normal community mental health treatment? There is literally, like, there is practically, there is no difference. It is essentially a parallel community mental health team, which is a little bit more resourced. It's more resourced in the psychology, with the family therapists and occupational therapists. So there are more people working in that team as compared to other, no, other teams. And secondly, this team is dedicated towards the first episode of psychosis. Otherwise, it is the same as any other community mental health team. So in the UK, what they do is that any patient who comes with the first episode of schizophrenia, schizoaffective episode, or first episode psychosis, or first episode schizophrenia, then in that case we tend to refer them to the first episode psychosis service or early intervention team. In the Republic of Ireland, there are very few teams, but these do exist. The idea is not having a team or not. The idea is that giving extensive treatment from the very start, as much as you can, especially with the especially with the what we can say is like the drug treatment, the medication compliance. That is the single most effective thing. Another thing which is Maudsley Prescribing Guidelines say is that the depot medication is better than the oral medication. So uh, it is it's better that if you can give depot on, and then nowadays I think there is a subcutaneous injection of risperidone is also there, subcutaneous depot. I think it's called RPR or something. We can talk at that about that at some other time. But anyway, the depot, earlier they go on a depot, the better it is, because the depot makes sure that the medication stays in their system. Otherwise, some people may stop the treatment altogether. Some patients may uh, start having gaps in the treatment, and especially when they're using substances, they stop the treatment. So that does the double damage. One is that they're using substance, and secondly, they're taking a break from the medication. So the summary is that relapse rates in the patients discontinuing antipsychotics are extremely high. Antipsychotics significantly reduce relapse, readmission, and violence and aggression as well. So they decrease the risk of aggression as well. And long-acting depot formulation provide the best protection against relapse. So we will continue with the multi-episodic schizophrenia next time, which will be the next Sunday, same time. So till we finish at that. Any questions up till now?
Sir, no, sir, thank you. The subcut injection you were mentioning was RBP. There are two types, so just wanted to add on to that.
Okay, let's go on to the B and F, and if we see if it is available in the B and F or not. So
I think it's not, sir. I think so.
yeah, so then maybe it is available in the states only. If it is not available in the BNF, that means that something is being used in the United States and it hasn't reached UK yet. So things generally they are most of the drugs they originate from the United States, and then
Right, sir.
then they come to the UK and then to Ireland. Sometimes they come to Ireland first and then UK, and sometimes most of the time they come to UK first. So tablets, risperidone. You can see my screen. So risperidone, there are tablets, and yeah, 3 milligrams, 4 milligrams, 6 milligrams, orodispersible. Yeah, another thing is orodispersible tablets. Like in Pakistan, you have the availability of the orodispersible tablet of olanzapine. That should be used. That makes the compliance a little bit better because the patient will not be able to spit out in front of you, and
Hmm.
by the time if you observe them for 10 minutes, it should have gone to the stomach. It will be absorbed by the stomach anyway, but so it will not be sublingually absorbed, but at least it will go to the stomach. Uh, because what the patients do is that they spit out the medication. Similarly, in risperidone, orodispersible tablet is available in the UK and Ireland, and then oral solution.
And in Pakistan as well, sir.
Or you have the orodispersible in
Yes,
risperidone.
yes, sir. Flash. It's Vizon Flash. One of the names.
Very good, yeah. And Dr. Inam or Dr. Rehan. I think it's Dr. Rehan Haq who has raised hand, so I'll call him in a while. And yeah, and then the suspension for injection. So it's not available yet, but it is something which is mentioned in the Maudsley Prescribing Guidelines. And then there are new antipsychotics coming as well. We'll discuss that at some other time. So Dr. Mohammed Rehan Haq, please. You want to take the
Okay, thanks for the presentation. I think it was quite helpful to catch up with things again. And just wanted a question about the response of medication. When do you normally, in your experience, change the medication when it's not responding? Say, is the first episode psychosis, you start an antipsychotic, it doesn't respond, and you think about uh, changing it to something else, like.
Yeah, so it's a good question. Some people actually jump from first drug straight to clozapine, but I think the consensus is that giving two medications before giving clozapine, trying, and I think I will stick with two. If some people do, that's fine. That's their practice, and that is also true. But my practice will be to try on two antipsychotics before going on clozapine, and that is the consensus opinion. Now, it is the duration of any one medication. Generally, from the very first dose, you should start seeing some response. In 4 to 5 weeks, you will see some response, and in about 8 weeks, you will see more response. So, if you are not seeing any response in 4 to 5 weeks, then that's what I was told by the British Association of Psychopharmacology when I attended their course, that they won't wait more than 4 to 5 weeks. So if they are seeing some response, of course they will go on and continue increasing the dose. If they are not seeing any response, they will probably stop it and switch it to some other medication. And I will do the same. You know, so I will go to 8 weeks only. Like standards in my mind is 8 weeks, but I will go to 8 weeks if I'm seeing some response at 4 to 5 weeks. Otherwise, I will change it. So yeah, Dr. Huck, any other questions, sir?
No, no, just this one. And sometimes actually we start aripiprazole as 10 milligram. I mean, if, from the start, but some people don't go slow, low and slow. I think that's the main, isn't it? Recommendation to go
Yes.
low and slow.
Yeah.
But some I've
Go.
seen some people start with 10 milligram aripiprazole directly.
Yeah. So I think we should go. We should follow the hyperbolic regime in both increasing the and decreasing the antipsychotics. So hyperbolic in like in discontinuation, even they say is that if you are discontinuing after 2 years, 3 years, 4 years, or 5 years, then discontinue it in a hyperbolic fashion, fast in the beginning and slow towards the slow towards the uh, end. So that's how you discontinue. Similarly, when you are going up, you give slow in the beginning and faster toward the end. That is the hyperbolic titration up, and that gives you a curve of a hyperbolia. Hyperbola. Uh, so that should be ideally followed. The thing with aripiprazole is if you give 10 milligrams, it will inevitably cause something like akathisia. So to prevent
Yeah.
akathisia, it is better to give something as give aripiprazole in a lower dose, and maybe uh, give some benzodiazepines for the first 2 weeks. The difficulty with benzodiazepines is some patients get addict, and you also as clinicians find it difficult to stop when they are started. So that's why there are kind of two kind of practices. Some clinicians don't give benzos at all, and some give in the first few weeks. So whether or not you're giving it, both are fine, but if you are giving it, make sure that you don't continue for a long time. And with aripiprazole, it may be needed for the first 2 or 3 weeks, and so that the akathisia doesn't develop, and then you can increase the dose afterwards. Any other questions?
No, thanks, fine.
Okay. So yeah, we'll meet same time next week then. All right.
Thank you, sir.
Okay. Love.